good morning. It's great to see you all here in person, and I'm super excited that we have so many more people joining us virtually across the country. We really appreciate you making time to be part of the conversation. I know how full your schedules are. I know how full my schedule is, and your willingness to lean into this moment of change in healthcare really does matter. So today I want to talk about something that may sound technical, but it's actually very human. It's operational leadership and burden reduction. Not theory, not slogans, not small tweaks around the edges, but the steady, practical work of turning what we've learned, especially from you, into meaningful, lasting improvements. To me, operational leadership simply means this. When we hear where the system isn't working, we don't just nod, we fix it. We take the lived experiences of clinicians, administrators, and beneficiaries and translate them into policy changes and system redesign that make daily life better. Over the past year, CMS has received nearly 1,000 letters from stakeholders. Many of you in this room are online, and you've shared thoughtful, specific recommendations on how we can cut red tape and refocus our programs on patients over paperwork. That level of engagement is extraordinary. And you talk to us personally as well. You don't send generic notes, you share real stories. You describe delays in care, documentation overload, compliance requirements that pull you away from patients. You told us clearly and candidly where the system is slowing you down. And we listened. But listening is only the first step. Operational leadership means moving from listening to action. So across CMS, we've taken a hard look at our requirements, line by line. We're asking simple but important questions. Does this rule truly improve patient outcomes? Does this reporting requirement meaningfully protect the program? Does this documentation help patients, or has it become paperwork for paperwork's sake? If the answer isn't clear, we're re-examining whether it needs to stay as it is. One theme we heard repeatedly was the need to address fraud, waste, and abuse, not only because of the dollars involved, but because fraud itself creates burden for everyone else. For those who know me, this was music to my ears because this is my sweet spot. Every fraudulent claim leads to new verification layers. Every bad actor results in more paperwork for good actors. Every loophole adds more friction to the system. That's frustrating and it's exhausting. So we're working to break that cycle. We're strengthening program integrity through smarter oversight, not heavier oversight. We're using advanced analytics and artificial intelligence to help us identify unusual billing patterns more quickly and accurately. We're improving coordination across agencies so we can detect fraud networks earlier. And we're targeting enforcement so we can protect beneficiaries without overwhelming legitimate providers with unnecessary administrative steps. The goal is simple: precision over paperwork. When we address fraud effectively, we reduce the need for broad, blunt requirements that burden everyone. But burden reduction isn't just about removing rules. It's also about redesigning how the work gets done. For too long, administrative complexity has been treated as an unavoidable part of public programs. I truly believe that does not have to be true. Complexity is not inevitable, red tape is not sacred, and friction should never be mistaken for accountability. When clinicians spend hours navigating prior authorizations, duplicative quality reporting programs, or repetitive documentation requirements, that's not a good use of anyone's time. It's time that can be spent listening to patients, thinking through complex cases, or simply being present. We want to help return that time to you. So we're aligning quality measures across programs to reduce duplication. We're streamlining enrollment and revalidation processes. We're modernizing data exchange so providers don't have to enter the same information into multiple systems. And we're working to make prior authorization more transparent, more consistent, and faster, so that decisions can be driven by clinical evidence and not administrative delay. And that's why today matters. We brought together an extraordinary group of leaders and innovators today to talk honestly about what transformation looks like in practice. Later this morning, Dr. Ling and a distinguished panel will explore how we can better manage chronic conditions, moving from fragmented episodic care to more coordinated and prevention-focused models. When care is better organized and outcomes improve, administrative churn naturally decreases. You'll also hear from leaders in health technology who are redesigning workflows so clinicians can practice at the top of their licenses, from experts focused on rural health and closing geographic gaps, and from innovators working on payment models that reward value and outcomes. There's a common thread that runs through all of it. We want to build systems that work for patients and for the professionals who care for them. A year ago, we set out with a commitment to strengthen CMS, not just as a regulator, but as a partner. And today, you can see that momentum building in the engagement we've received, in the collaboration across sectors, and in the energy in this room. When administrative systems become too heavy, everyone feels it. Providers burn out, patients wait longer, innovation slows. We all know that. But we also know that CMS has an outsized role in shaping how the healthcare system works. The decisions we make ripple across hospitals, physician practices, rural clinics, nursing homes, and community health centers nationwide. With that scale comes responsibility, but also real opportunity. It's an opportunity to set standards that simplify rather than complicate. It's an opportunity to modernize infrastructure so it keeps pace with technology. And it's an opportunity to align incentives so prevention and wellness are truly central to care delivery. So I invite you to think of today not just as a conference, but as a working session, a chance to be candid, a chance to share what's working and what isn't, and a chance to help us to be able to continue translating ideas into action. I want to thank you for your partnership. I want to thank you for your honesty, and thank you most of all for the work that you do every day to care for patients and communities across the country. And now I hope you will join me in thanking the team that put all this together with a big round of applause for the organizers of this conference. And in what has to be the most perfectly timed entrance ever, I will now turn it over to Dr. Oz, our administrator.
What do you need?
Yeah.
Kim is an absolute superstar in ways you cannot imagine. She runs, she's Chief Operating Officer, a lawyer, fraud, waste, and abuse, HR. You pick it, she's doing it. God bless you for taking time to do something that's so important to us. Absolutely. We had a retreat this past weekend. I did it last year just to get everyone to know each other, but this year we did it as a working, intense 3-day event where we got into a lot of opportunities, some of them I'm going to discuss with you. But we were asked to tell each other one thing as a bit of advice, and my request of Kim was to learn the most powerful word in the English language, which she really doesn't have any knowledge about. She said it's no. Just say no once in a while. She doesn't, and she should. But without her, we wouldn't have this conference. We wouldn't have some of the advances that are taking place. So I thought I'd take a step back as a physician. How many clinicians in the room? Nurses, doctors, good number. And speak a bit about professionalism and what we should be doing at CMS to make it easier for people to be professionals and to allow folks to achieve their dreams, which is, of course, why many of you sacrifice so many hours of your day to take care of other human beings. It's a remarkably rewarding experience to look someone in the eyes and to make sure that they know you're there for them, and to have them express appreciation and trust in your advice. And our ability to have that precious covenant, that sacred moment continue, especially in doctor's office or wherever the clinician is. It could be a pharmacist and, as they're doling out a prescription, trying to help them with some basic issues in their life. Those need to be preserved, those moments. And that's what has allowed medicine to thrive for so many years. But I do believe the medical profession has lost its mojo. And I say that because it seems like over the past several years, when there were issues that should be debated and where America looked to its professional class for advice, we were not there, at least loudly opining on what we think should happen. We don't have to agree with each other, but I think we should agree that people want to hear from us. I think we were silent on some critical issues that many of us probably had strong feelings about with regard to COVID. We've been silent on other issues. And again, I'm not calling for unanimous decisions on these issues. I'm just saying we should be allowing enough, or at least acknowledging equipoise in how these discussions are happening so we can start speaking out about themes. Because what is a professional? A professional always puts their patients first, right? Hippocratic oath. We help each other, stand on the shoulders of each other, teach the next generation to allow them to rise above us, to advance the science and the care of individuals that trust us. We have an obligation to police each other. We don't do that so well. It's not our culture. We don't go to medical school to litigate. I remember when I was in medical school, we had a pizza party with the lawyer, with the law school. Very different people. The doctors are cutting the pizzas for each other. The lawyers are fighting about who paid more. So it's just different. Not good or bad. It's just very different people. You need them all to make the bouillabaisse of society work. But there's a fourth part of being a professional. It's a civic responsibility to speak out, to take some chances. And we cannot ostracize people when they do that. Now, my bias on medicine is colored to a large extent by my father, who came to this country as an immigrant. He came legally. At the time, America was recruiting doctors. And my father was picked to come, in part because he had the misfortune, or maybe fortune as it turned out, to be trained in Istanbul, Turkey during the Second World War. Now, the reason that ended up being a fortunate moment, despite the fact that it was the middle of all this intrigue, is that the Nazis did not want to attack Turkey. They were hoping they'd become part of the Axis. And so they allowed refugees from Europe to come to Turkey, including Jewish physicians who were being chased out of Central Europe. And my father was trained by Nissen, who also taught the Nissen fundoplication, and numerous other clinicians whose names may not be as famous, but this incredible cadre was in Turkey for, a dozen years maybe, and they trained the generation of physicians. And so my father was, because America was watching and was intrigued by the opportunity of pulling these physicians who've been well trained back into this country, he came. He could not believe America existed. And I remember scurrying along next to him as he made rounds when I was a kid, and watching him do things like put a needle in someone's throat and have them thank him for doing that. Like normally you don't thank people for hurting you. But in our medical field, we allow that to happen because people trust us to be doing the right thing. So we do have an opportunity as a profession to speak up, and people will take us at our word when we do that. And so I thought I'd spend a few moments talking about what we can do to change the burden that we inappropriately place on clinicians, on hospitals, on pharmacies, all the caregivers within the healthcare system, that I don't believe increases the value as much as it should. So we together should decide we're either going to continue putting a burden on the system and make sure we get more for it, or reduce the burden so that we don't have to take effort, angst, because I think most people leave the field not because of the pay or any other factor, other than the fact that the reality that the hassle factor is so large that this stops being fun. And so we have been working aggressively to address this, and they're put it in a couple different categories. There is a whole movement, a workflow on technology, which I'm going to speak to a bit. There's a movement towards MAHA, which I'd like to define for you. And then I want to talk about a couple programs that I'm proud of that we've been able to implement that I do think makes a difference. So Kim touched on some of the efforts in fraud, waste, and abuse. We've got another big announcement this afternoon at the White House on this topic. And part of the way that we're trying to get ahead of fraud, waste, and abuse is to learn from what other sectors of the economy have done. So you think about a bank. How good is a bank manager at bank fraud? Probably not so good. They don't study that in banking school, right? We don't study that stuff either. So we're not very good at thinking the way a fraudster thinks. What happened in banking is they began to use technology, AI in particular, to imitate and predict what fraudsters would do in the banking system. Why? Because although a bank manager can't think like a fraudster, AI can. And it actually helped equal the playing fields. We need to do the same thing within our field, to look for not just data aberrations, but predict where the problems would be if you were a fraudster and we're looking at the system. And by doing that, get ahead of some of these problems so we don't have to pay and chase. We can just stop the payments, never let it leave the building. And that's why Kim's role in that is important, because part of the regulatory apparatus was built to prevent the bad guys from getting away from it. All it really does is prevent the good guys from doing their jobs. So how do we adjust to make sure? And right now, we've made the path to health a fairly convoluted one with detours around paperwork and process and profit. And that's the relationship with the clinician and the patient that we're interfering most with when we impose those rules. And it's our job to make sure that folks get the health they deserve, but they should get it in the way that makes the most sense for them. And we're always going to put patients over paperwork in this administration. So we have an obligation, a duty to look beyond what's currently out there. And we need your insights today, which is why you're going to have you'll be regaled by some wonderful speakers trying to make sure you're on the same page with us, but we also are on the same page with you and understand where your issues are. There's no question that technology and AI will help us. How it does it is going to be part of the game. And in reality, much of it's not a technology barrier anymore. It's a cultural barrier. Can we really implement these issues, these technologies into our day-to-day life? And by doing that, begin to come up with some even bigger ideas going forward. We have a big initiative at CMS just to get people to use AI in their day-to-day lives to get home earlier, to write memos, to understand emails, just to process complexity more effectively in their own lives. And by doing that, they'll get more facile with tools that could definitely help us write programs to catch fraud faster, initiatives that would generate solutions that no one would have thought of because they don't have the domain expertise of what you all have in this room of understanding how the burden of the system we've created is influencing care and where are the opportunities to make it seamless in its ability to deliver quality metrics without hindering the quality of care. We want to be smart with our solutions. We want them to be secure. We want to reduce administrative burdens for everybody across the entire gamut. And that means we are going to do things like killing the clipboard. So we don't have QR codes, rather clipboards blocking our path when a QR code can deliver the same information. These are changes that are going to dramatically change, alter the experience of patients when they walk into our offices, and it's going to happen in this administration. I looked yesterday at some of the pretty cool onboarding tools that we're making for Medicare.gov. It's a very different experience, one that will seem much more like every other sector of the economy, and there's no reason for health not to play in there. We want patients to be world experts at their own health. We want doctors to be mediocre at best at coding. Now, we're not often advised to be mediocre, but I think this is a place where none of us want to be world experts. And frankly, coding, if it only predicts, let's say, 15% of the variation in quality next year, may not be worth the squeeze. Or we need better ways of doing coding, to make it that coding automatically garnered and not cherry-picked so that it can be gamed and thus throwing off its accuracy. We must have prior authorization at a rate that makes sense. And just to emphasize, prior authorization is something that the insurance companies don't seem to like that much either these days. But it's a big target on their back. It doesn't work as well as they desire. And they spend as many hours as clinicians spend in their businesses trying to adjudicate this. So you've got 12 hours for the actual average doctor, 12 hours for the average insurance company. Can we do it in a better way? As you know, we challenged the private sector to take this on last year. The insurance companies representing 80% of the American people got together and did just that. And by the end of this year, they've committed to having 80% of prior authorization done almost instantaneously, near immediately, which takes away the angst of not knowing whether you can get that test or not for a week or two or longer. Clinicians can get immediate feedback so that they can rapidly change what they're submitting so that they can adjust if the patient deservedly should have a procedure. But I want to actually challenge us one step further. Is that the best system? And it turns out when you pull people together, and remember, CMS we influence Congress across the street to pass laws. We give technical assistance when those laws are crafted. We're regulators, right? We make rules, physician schedule, fee schedules, et cetera. But we also are payers. And because we're payers, we have the ability to use an additional lever arm to influence industry. And that allows us to maybe take advantage of a completely separate path to help the system work better. And that's the power to convene. Can we get industry to come together and do things on their own, which is a much more nimble and fast and litigation-free, generally, approach to changing the system? So in the case of prior authorization, when we did that, we began learning about gold card programs, which many of you know about, that seem to provide additional incentives. Why? Because every doctor, you all know this, every doctor, every nurse finished top half of their class. And because we all really believe that, we don't like it if we don't have a gold card and someone else does. If the gold card denotes that you're practicing medicine in a more evidence-based fashion, I want one too. And so now I'm going to change what I'm doing to get a gold card like you. Plus the gold card lets you get people through the system without prior auth. And I'm stuck over here with tons of paperwork dealing with a problem caused because I wasn't practicing evidence-based medicine, or at least adjudicating my decisions. But here's the better part to it as well. A different level of influence. Patients can now start tracking gold cards. Now the patient says, I like Dr. Oz, nice guy, but doesn't have the gold card. What gives? I can ask the doctor. Why doesn't he participate in the ways that other doctors do? And this is the kind of natural ecosystem we want to build. It's the same ecosystem that our tech teams are building. Because if we have patients owning their own records, we can now give you power to take those records through the healthcare system. Ultimately, those records are yours. You paid for them, one way or another. And so the health tech ecosystem that Amy Gleason and Alberto is going to speak to in a few minutes about this has been remarkably effective. I mean, shockingly easy to get every tech company to participate voluntarily, signing a pledge that they're going to help us with interoperability, transparency. They're going to work with us to build tools for patients. We started with 60 big companies. All the companies you probably heard of signed the initial pledge at the White House last July. But now we have over 600 companies. Literally every company you can probably think of has signed up to be part of the health tech ecosystem. So we will very soon, and Alberto will speak to this, be giving companies, tech companies, access to the American people, where we will for the first time start paying for app solutions to meet Americans where they are and give them tools to help with their A1C if they're diabetic or metabolic syndrome, or their blood pressure, or the downstream complications from these issues, or the upstream cause of those problems, which is often obesity. But we're only going to pay for outcomes. We're not going to pay for churn. We're not going to pay because you engaged the patient. We're going to pay because the patient engaged you, did the things you asked for, and got outcomes that correspond to that. And that really is a major reality of the MAHA movement. Because what is the MAHA movement about? It's about one word: curiosity. Are you willing to ask questions, real questions? 80% of questions are statements in disguise. Are you willing to ask questions about the challenges that we're facing in America, that explaining why it's so much harder for moms today to keep their kids healthy than it seems like it was even a generation ago? And if we can ask that question, and we're courageous enough to ask the question and act on it, and compassionate in how we talk about it, you'll start to get people to think differently about why we have made it a challenge in this country. And if we make it easier to be healthy in America, that's what MAHA is about. So many of the things that Secretary Kennedy's been pushing for, like for example, the food pyramid that was turned right side up, even though it looks upside down. Some of the challenges that we've been able to overcome with everything ranging from food dyes to SNAP waivers to get states to be able to push healthier food on folks who are most of need. The 42 million Americans on SNAP are generally more likely to benefit from healthy food being given to them than others. That's a remarkable advance. We've also taken legislative action. The Rural Health Transformation Fund, $50 billion being poured into rural health care. The 60 million Americans who live in rural parts of this country do not have access to the same services that the rest of urban America has. And the reason for that is Medicaid money rarely goes to those rural areas. It only gets about 7% of the Medicaid budget. So we are 50% increasing the amount of money, 50% increase the amount of money we're putting into rural health care. And we're doing that not to pay the bills. You don't put 50% more money into a system to pay out, old debt. You put it in there to transform the system. And we transform the system by letting technology roll into these facilities. Group purchasing, let big hospitals adopt small hospitals, not own them, adopt them culturally to help them function better, to provide higher quality experiences for Americans living in rural America. And Dr. Ling's going to speak to some of these issues in a bit, but part of it comes down to getting the best people in the room. Now, we have a federal advisory committee, a FACA, that we've created that pulls together top leaders who will help us with burden reduction. 15 Americans were picked from the 450 applicants. It was hard to whittle down 450 to 15 people, and I'm going to be the first to say that it's not a perfect process. Picking the top 100 was easier than picking the top 15. And the people who did not get picked for the FACA, we are putting on the subcommittees to continue to give us advice. We want your feedback. We're open for business. In fact, we're recruiting people. That's why you're here, by the way. This was a recruitment meeting. We need better people, top-notch people. We already have a fantastic team. We don't have enough of them. And so Kim is out there recruiting hundreds of more folks, especially clinicians, folks who have experience in the provider space. We need more folks to help us do our job. And let me leave you with the belief that the clinical world is a massive investment for our country. But despite spending twice as much as any other country per capita on its healthcare, our healthcare results continue to drop. And they're dropping for a bunch of reasons, but some of it's inefficiency. Inefficiency caused by fraud, waste, and abuse, inefficiency caused by a burdensome a regulatory apparatus that doesn't actually help as well as it should. So I encourage you, I plead with you to be tough in your feedback to us. Where are the big strokes we can take to reduce the burden that we place on the healthcare system, to allow it to function, come up with better ideas than we have, push us to adopt them, criticize the ones that we currently have that aren't working so we can move aggressively to reduce them. We actually have in our OKRs, our objectives and key results, metrics that push us to reduce by a significant amount the amount of rules that we ask for. We've already taken a bunch out. That's uncommon for government to get rid of a regulatory apparatus, even if it's not working. We intentionally wish to do that. I was sitting in your chair a year ago. I'm coming from the private sector. I know what it feels like to be burdened by a system that doesn't seem to pay attention to you. We want to at least be responsive, or at least explain why we're doing what we're doing so we can get honest feedback from you. To do that, you have to be meek. Now, why am I asking you to be meek? Why does the Bible implore us or advise us that the meek shall inherit the earth? The word meek, I used to think meant weak when I was a kid, but it doesn't mean that. It means you're strong and powerful and you're armed, and you're willing to take that sharp sword and sheath it and put it away for a while because you've got to sit down with your brethren and figure stuff out. We're in that time in the healthcare system in America. You have a government that wants to be responsive to the challenges that you see. We want to be there with you. We ask you to be meek for a short period of time so you can play that role. Now, I can't think of a better person to help broaden this concept than Alberto. Alberto Colombiera is a superstar. Was in the agency when we got here, has been able to take an incredibly complicated process and make it accessible even to a heart surgeon. And because of that, he, together with Amy Gleason, Arda Kara, and a whole slew of wonderful people, has built a tech transfer ecosystem, a center of gravity here at CMS that's allowing us to engage with industry, engage with a sector, the tech sector, that historically has only been involved in downstream, really sophisticated clinical tools. That's why technology has generally been inflationary to healthcare. We believe technology, if used at its very core processing of healthcare, could be deflationary. It could make the system run more efficiently and maybe do that by reducing the regulatory burden on the system to allow you to redeploy those resources, take care of the American people. So Alberto, come up here and regale everybody with your wisdom.